Repeat that, I missed that.
I said, did you open the screen or the web for the people, for our
Yeah,
attendees?
okay, I'll open that now. Just 1 second.
Yeah, sure.
So,
Ibrahim, you want to introduce first or what? As a company? Or you want me to do the introduction, the whole thing?
You can do the introduction, Dr. Wael, and you take it from there.
So the chairman is starting the introduction, and then the speaker start. So nothing to do with
You do it.
boss.
Yeah, go ahead. We'll take the دقيقتين can you start why?
محمد go ahead حبيبي start you. يعني انت
It's 2 minutes.
احنا جايبينك خصيصا
2
كده.
minutes. 2 minutes. 2 minutes. 2 minutes. شباب.
Yeah, I can see attendees jumping. There are around 16 attendees so far.
Good. Very good.
ليه؟ خذ من هذا.
Okay, Bismillah ar-Rahman ar-Rahim. Good night, everybody. It's a pleasure to be with you and Dr. Wael Kashqari, who is the president of SASIS today. We are together, and we would like to thank Boston Scientific for arranging this webinar and to welcome our friend and colleagues, Lady Baker from Copenhagen, Denmark, Europe. Tonight, Ole, he will talk to us about like a critical appraiser about the ACURATE IDE trial, which was presented recently in TCT. And after his presentation, we're going to have a short discussion. Then we will go to our young colleague and they present their nice cases. Ole, the floor for you.
Yeah, Mohammed, thank you for the introduction. And indeed, I'm Ole de Bakker. I'm a structural interventional cardiologist, full-time structural in Copenhagen, in Denmark. And I'm going to share with you, with pleasure, the following presentation. I hope you can see it already in full screen. So this is indeed about the ACURATE IDE trial, which was presented at TCT recently, a couple of weeks ago. And of course, as you know, there were some surprising results there, but to give you especially some background and some deep dive on some critical results from this trial. So as you see, this trial was, it was a 1-year outcome results of the ACURATE Neo versus approved TAVR devices in all risk patients with severe AS, the ACURATE IDE trial, which was run the previous years in the US mainly, and it was presented by Michael Reardon at TCT. This was involving the ACURATE Neo 2 platform from Boston Scientific. Probably most of you are familiar with this platform, but still, as a small summary, this is a self-expanding TAVR platform with a supraannular leaflet position, an interesting deployment top down. So you open up first the top part with the stabilizing arches, which makes it very nice self-centered, the valve, and then you do the lower part, the stent body expansion on the inflow part. So you had the available sizes in the study were 23, 25, 27 millimeter. Nowadays in Europe, we already have also the ACURATE Prime, or maybe already also in the Middle East, I don't know. But we also have the ACURATE Prime now, which also gives the 29 millimeter, the possibility to treat large valves. But that was not the case in the ACURATE IDE trial. So what the ACURATE IDE trial was about? Well, the trial design was a classical IDE trial design. So this is trial design to get FDA approval for a specific product. So this is typically a large trial. This trial was up to 1,500 patients, one-to-one randomization versus ACURATE neo2 versus the control, which is already FDA approved. And that is in the US at that time when the trial was conducted, it was SAPIEN and Evolute. As you see in the control arm, here there was 2/3 of patients were treated with the SAPIEN valve, the SAPIEN 3 or SAPIEN 3 Ultra, and only 1/3 of this control arm was treated with the Evolute, Evolute R, Pro, Pro Plus, or FX. And important to say, this was not a randomization. This was purely picked by the operator's preference. Yes, this control. So that makes it, of course, also harder for the ACURATE neo2 to kind of win from a very patient-tailored choice by the operator. And then the primary endpoint of this trial was a composite of all-cause mortality, stroke, so all stroke, or rehospitalization at 1 year. Okay. So then the non-inferiority was, of course, a non-inferiority trial, as they just wanted to obtain FDA approval with this trial, and the non-inferiority margin was taken at 8%. I'll come back on that later, what that 8% means for this trial. Just some background how this trial was conducted. Well, the trial, as you see, was just started, initiated in the US in June 2019, for 5 years ago. And it actually ramped up pretty nicely with inclusion. But then, as you all know, in February, March 2020, we were all very badly hit by the COVID. And of course, there you see that the inclusion really plummeted, because there were no clinical field specialists allowed in the cath labs. There was, even for some period, less TAVR volume. But even if the TAVR volume ramped up again in most of the cath labs, this was typically done with valves that most of the operators already were implanting at their centers. So you see, it was a quite protracted time to enroll these all these 1,500 patients in the trial, which made it very hard. It was also impossible to fly in, for example, experienced ACURATE implanters or proctors from Europe or from Middle East, for example. I don't know if there were experienced people already in that time, but at least there was no possibility to get experienced clinical field specialists or proctors over to the US. And you also see another issue was also that the experience with the ACURATE neo2 in this ACURATE IDE trial was really low with the implanters. You see that 72% of the physicians implanting this valve in the ACURATE IDE, they had 5 or fewer cases over the course of the entire trial. So this is really dramatically low if you have experience of less than 5 cases, and only 10% of the implanters, they did more than 10 cases in this trial of the ACURATE neo2. So this is all, well, I would say suboptimal conduction of the trial, which was, of course, not ideal. You see that one-to-one randomization that was respected, 750 in both arms, and the clinical follow-up was really well up to 91, 92% of good clinical follow-up in this trial. You see that despite this very low experience with this valve, that the procedural outcomes were actually really good. I mean, if you see here to correct positioning of a single valve into the proper anatomical position, despite having almost no experience with this ACURATE neo2 platform at all, you see that this was successful in 98.4%, nearly the same as in the control arm. There were very few procedural complications. So that also confirms to me, when I have to train my fellows in my center new valves or TAVR platforms, I see that learning an ACURATE implantation is really, really easy. The learning curve is really short. Typically, if you've done 5 to 10 cases, you kind of master implanting this valve. This is not the case with some other platforms which are harder to learn. So that was good. Also, the echocardiographic outcomes were really excellent, I would say. We know that the ACURATE platform has really good hemodynamical outcomes, as good or even slightly better than ACURATE sometimes, than Evolut sometimes. So thanks to a supra and a leaflet position, but clearly performing better than the balloon expandable valve. And also PVL wise, paravalvular leak or regurgitation wise, they are on par with the Evolut platform. So also there, no issues. But then you see that there was some issue with the trial, which comes from the day 30. So you see up between the procedural day 0 and 30, the two curves between ACURATE neo2 and the control arm, they run kind of parallel. But from 30 days on up to 1 year, there's some kind of diverging curves with more events of that stroke or rehospitalization in the ACURATE neo2 arm as compared to the control arm. You see here on this slide the real primary outcome at 1 year, which was 14.8% in the ACURATE neo2 arm versus 9.1% in the control arm. And you see that this was mainly driven by more late strokes. So this was, of course, surprising. This was not something we had seen in the European large registries, where actually these data were actually really, really well. And you see that the primary endpoint was actually missed in this trial. You see that the non-inferiority margin was set at 8%. The difference between the control arm and ACURATE neo2 for the primary endpoint at 1 year was 6.6%. So this was less than the preset 8%. But you have to understand that you miss the non-inferiority if also your 95% confidence interval goes beyond this 8%. So the difference in absolute percentage was 6.6%, but the confidence interval, the 95% confidence interval, was 3 to 10.2%, and this 10% surpassed the 8% non-inferiority margin, which made that actually this ACURATE IDE trial unfortunately did not meet the non-inferiority for the primary endpoint. Of course, people have insights, people from the company having already knowledge of these data. They were extremely surprised by these outcomes, given also the really good outcomes in other sites, in other parts of the world, be outside US. And there was a deep dive investigation to the root cause of what caused this especially late strokes. And so many of these, or all of these cases, actually, I was kind of involved in this, all of these cases were investigated and checked. And what was found is that quite a good number of patients in the patients which had events, clinical events, that they had underexpanded valves. And these patients with underexpanded valves, which was around 20% of patients in the ACURATE IDE trial, they had an increased rate, a twofold increase in stroke and a threefold increase in stroke and a twofold increase in mortality. So you see that here, if you had an underexpanded valve, which was in 20%, 1 out of 5 ACURATE valves had a severe underexpansion, you see that especially the stroke rate was 11% at 1 year, whereas if you have a very well expanded ACURATE implantation, actually you see that the outcomes, the clinical outcomes, are completely on par with the control arm of SAPIEN Evolut. Also for mortality, exactly the same signal was seen. So we really detected an issue there of valve underexpansion. And this was especially seen by the non-parallelity of the commissural pulse. You see here the ACURATE platform. We had all the fluoroscopic views from the procedural implants, and you could clearly see that some of the valves had a non-parallel commissural pulse, and I will show you later from bench tests. We know that this could reproduce in bench tests, as this has to deal with underexpansion, severe underexpansion of the lower body stand frame, especially close to the upper crown. If that part is underexpanded, you get this non-parallel commissural pulse. So going back a little bit from the ACURATE IDE, this issue of underexpansion was detected. So the whole question is, well, is this transcatheter aortic valve underexpansion Is this a complete new finding? Is it complete? Are we completely surprised? Is it never been reported earlier? Well, to me, at least, it was not a surprise at all. I mean, if you look back in history in the last 10 to 12 years in literature, there are a couple of signals already down the line that shows that valve underexpansion in TAVR is a problem, a possible issue. On the top left, you see, for example, these are three papers from Jack Cardiovascular Intervention, and also later a field notice from Medtronic on the infolding issue in evolute. So infolding, it can sometimes infold, especially in very calcified anatomies. And this also led to a real severe field notice to all operators in the world to warn for this phenomenon. Also in 2017, so this we're talking about 7 years ago already, in Copenhagen, I initiated a study together with a friend, a cardiologist, CT specialist. We had a lot of post-TAVR CT scans to our availability. And we were also one of the first, together with Raj Mukar and Cedars-Sinai, we in Copenhagen, we published together in 2015 in New England Journal of Medicine, the founding of leaflet thickening, the leaflet thrombosis on TAVR devices. This was published in 2015 as a first, and I did some further deep dive analysis. And to me, I found this was then mostly in Portico valves, now it's Navitor, we had in these platforms quite a lot to deal with leaflet thrombosis or leaflet thickening. And I found, and I reported in your intervention 7 years ago already, that this was linked, this was associated with underexpansion of valves, of these particular valves. You see here, if the leaflet, normally the leaflet should be 120 degrees, like a Mercedes star, 120 degrees expanded. But if the leaflet is 90 degrees or less than 90 degrees expanded, you see that the leaflet thrombosis or the leaflet thickening rate goes up to 50% of these leaflets have actually leaflet thrombosis. So already 7 years ago, we knew that something could be wrong if a transcatheter aortic valve would be underexpanded. This was confirmed in 2022 by a group in Minneapolis, the Minneapolis Heart Institute, led by a study led by Vinny Babat, that most of you know from the Redo TAVR app or the Valve in Valve app. They found exactly the same. So if you have valve underexpansion, and this was also not only for self-expanding platforms, so don't misunderstand me, this is not only an issue of self-expanding TAVRs, but also and especially also in balloon expandable valves. If you have this kind of deformation or underexpansion of the SAPIEN valve, they also reported that this was linked and associated with leaflet thickening, leaflet thrombosis, and they were also the first to link this to worse clinical outcomes, also especially late strokes. Yeah, so again, this was not a new finding. And then you see the papers, the studies on the right-hand side of this slide. These are all studies from 2024. So you see that people and researchers around the world, they start to appreciate the issue of TAVR underexpansion now in 2024. These are just a couple of examples. This is a very recent publication from 2-3 months ago from Bern in Switzerland. Again, they also report in balloon expandable valves, if you have an underexpansion of the valve detected by asymmetrical expansion of the valve, that these valves are also more prone to have prostatic valve dysfunction. And also an interesting paper here from, again, Cedars-Sinai from the Raj Mukar group. This is also SAPIEN in bicuspid anatomies. And you see, luckily, 50 to 60% of sapiens and bicuspids are well expanded and have a good circularity. But unfortunately, there is around 25 to 30% of patients with an underexpanded valve or an eccentric expansion. And even 15% of patients, they have both an underexpansion and eccentric expansion of the SAPIEN valve in bicuspid. And if you see what the consequence of this is, you see here in the halt. So if you have an underexpanded and eccentric, severely eccentric SAPIEN implant in a bicuspid valve, you see that the leaflet thrombosis rate also goes up to 60%. So again, a real issue for these valves, and also clinical endpoints. There is more stroke, more mortality in these patients. So this is just showing you that clearly valve underexpansion can have consequences for your valve function. and for clinical events for your patients. Also, what they found in, for example, bench tests from the ACURATE valve, and this could be reproduced also in other TAVR platforms. If you have a severe underexpansion of your TAVR device, like here the ACURATE, then you also get trouble with the flow. So normally, if you have a well-expanded ACURATE platform or other valve, transcatheter aortic valve, you restore the laminarity over the valve, and you have a good, appropriate, adequate washout in the sinuses. However, if you have a severely underexpanded ACURATE valve, you see that the flow through the valve suddenly becomes turbulent. It's not laminar anymore. You have a reduced washout in the sinuses, which makes it more prone for thromboembolic events. And also you see on the leaflets, you see here on the left bottom picture, you see that there come creases on the leaflets, which these can act as a nidus for microthrombi. So underexpansion of TAVR devices is not a benign phenomenon. And you see this not only on the ACURATE platform, you see this also can be reproduced in the bench test, in the Navitor, in the Evolute, also in SAPIEN, as I showed you earlier. So disconnecting a little bit from ACURATE IDE, now I go to the last 5 to 10 minutes of this presentation. What did we actually learn for this in clinical practice? Well, I think if we look to the ACURATE platform, it's important to realize how the design of this valve is. And if you understand how the design of this valve is, then then you understand why it is important to have a proper expansion of this valve. Because you see, you have a stand body on the lower part, the inflow part, to push the leaflets on the side. But then it's really key for this valve that the upper crown, this is here, the upper crown, that this area between upper crown and the commissural post, that's where the leaflets of the ACURATE are positioned, that this region is well expanded. Because if it is not expanded to the upper crown, then you will get indeed this turbulent flow and bursar washout and creases on the leaflets. Also, what is important if you use this platform is the pre-dilatation. A good pre-dilatation is really key for a proper functioning of this valve and a proper implantation of this valve. And that is simply because it is a top-down expansion of this platform. It does not interact for a long time initially with the leaflets and then you open it up to the top. No, you open it up on the top, and then in less than a fraction of a second, you have to open the stand body. So you have to understand that you have to modify the calcium and break the calcified leaflets up front. If you do that in a good way and you get a proper expansion of the valve, then you have a nice implantation of your ACURATE platform. As you see here, this is an example of a real case with a good ACURATE expansion. This was also in 80% of cases in the ACURATE IDE trial. But unfortunately, I showed you already, we know that we detected 20% of ACURATE implants here with a severe underexpansion. You see, this is, for example, a case with severe calcium, probably on the non-coronary cusp, which has an indentation on the body stents, the stand body of the ACURATE platform, and then it goes together hand in hand with such a non-parallel commissural post, and then you get these clinical events. So what are now the procedural steps to optimize the index transcatheter aortic valve implantation? I would generalize this for every valve, but especially for the ACURATE valve. Well, first of all, you need an effective pre-dilatation. And what is an effective pre-dilatation? Well, you have to look to the anatomy of your patient. If your patient, this is an example, the red ring is around 24 millimeter. Well, if you go pre-dilating with an 18 or 20 millimeter balloon in an annulus, which has a mean diameter of 24, this is not going to be an effective pre-dilatation, yes? Unfortunately, many of the pre-dilatations in the ACURATE IDE trial in the US, they were done with far too small balloons. There were even centers who were doing, the pre-dilatation was quite high. The pre-dilatation rate in ACURATE IDE was up to close to 95, 98%. But there were centers who pre-dilated systematically with an 18 millimeter balloon, regardless of the anatomy and the size of the patient's anatomy. So this is, of course, a mistake. I mean, this is not an effective pre-dilatation. And you can see here already, just maybe you think that maybe the difference between a 20 and 22 millimeter balloon, what's the difference, you would say? It's only a small difference, 1 or 2 millimeter. Well, that's not the case. I mean, if these 1 or 2 millimeters differences, if you look to the area that balloon finally expands, it's a much larger area that this balloon can get open and inflated in. And of course, that's important. You see, this is, for example, a scenario where you have a non-coronary cusp, which is extremely calcified, the right and the left much less. If you use an 18 millimeter balloon, as it was often done in the ACURATE IDE, well, you inflate the balloon, the 18 millimeter balloon will easily inflate, but you will not modify any of the severe calcifications on the NCC because the balloon takes the position and goes to the location of the least resistance. So that lets you understand that if you go for a too small balloon systematically, you will not modify the calcium there where it's actually just mostly needed. So first, effective pre-dilatation, then you do your valve implantation. And it's also important, and that was also a mistake, I think, in the ACURATE IDE trial, that physicians were, and this was also a mistake, I think, from Boston Scientific. At that time, they did not know of this issue, of course, of underexpansion, but they advised the operators just to stick to only the tricuspid coplanar view and for sure not use any other views. Well, we in Europe, we were already using systematically cusp overlap views because we did commissural alignment. We were experimenting with this. We came up with that idea in Copenhagen, and since then many centers have used this. So we used already two different orthogonal views, like tricuspid coplanar view, REO views. This was not done in the ACURATE IDE trial, and we know that to detect underexpansion, it's really important that you use two orthogonal views. You cannot, sometimes you miss underexpansion in one view, but if you go from an LEO to an REO view, then you suddenly see a severe underexpansion of your valve. So you also have to check this from two fluoroscopic views. And what are the three ways now to identify an underexpanded ACURATE platform? I told you already, if you have a non-parallel post, commissural post, if one of the commissural posts is not nicely parallel with the two others, that's a sign that the upper crown region is underexpanded. Secondly, if the valve frame is taller, up to the upper crown is taller than its width, yeah, then you also know you have to deal with an underexpanded valve, because we know from the top of the upper crown to the inflow part, this is exactly 19 millimeters. So the smallest valve on the market is the 23 millimeter. We also have 25, 27, and nowadays we even have the 29. So if the valve is not as wide as it is tall up to the upper crown, we know immediately it's underexpanded as well. And then for sure, this is an important one as well. If you have a trapezoidal trapezium kind of body stance, you already can appreciate, of course, that the valve inflow is nicely expanded, but the upper crown region, there where it's just critical to have good expansion, it's underexpanded. So then you also have to go for a pulse dilatation. So pulse dilatation, most operators, most of us, we already, before we knew the ACURATE IDE trial data, we got the incentive to pulse dilate if we saw either a paravalvular leak, which was a bit too much, or if we had not optimal or suboptimal hemodynamics. Most of us would have gone for a pulse dilatation. I think now there is a third incentive to go for pulse dilatation, and that's if we see a severe valve underexpansion, not only of the ACURATE, but also of other valves. And I can tell you, even in the US now, there are many operators, even if they do balloon expandable valve implantation and they see after the first implantation of the sapien that the valve is kind of the deformation, it looks like an hourglass. Yes, it's like shaped in, it's very severely underexpanded. They do nowadays much more double tap implantations, they call it. So they do repeat the inflation of the balloon. So they do initial implantation of the valve. If there is severe underexpansion, they use the same balloon, they use a second run of pacing, and they pulse dilate the valve again. And then very often you can get rid of this deformation and expand the valve better. So there is more appreciation in the TAVR community that valve underexpansion is not a good thing to leave behind, because your valve, you expose your patient to early valve failure and maybe also even late strokes risks. So you see here, pulse dilatation can be very effective. If you have this non-parallel post, and you do an effective pulse dilatation, you can definitely address this issue of underexpansion. This is a case, for example, in Copenhagen. I'm sure I do a good pre-dilatation, but this is an extremely severely calcified valve. Despite the good pre-dilatation, of course, because of all the calcium, the valve is underexpanded. So if I see this underexpansion, I immediately go for post-dilatation, and you see how much I can actually expand this valve further. You see here, and there's hardly any recoil, and then I have a nice implantation with nice symmetrical commissural pulse, no paravalvular leak, excellent hemodynamics. So the second last slide, what kind of balloon size should we use for the pulse dilatation? Well, I would say it's typically guided by the patient's anatomy. So if you have your perimeter-derived mean diameter, annulus diameter of your patient, and you subtract 1 or maximally 2 millimeter, that's typically the balloon size we're going to use. Also, if you're working with a 23, the small, medium, or large, or the extra large valve, the balloon never to exceed is actually the 22, the 24, 26, or 28 millimeters. So the labeled accurate valve size -1. But you will typically never use this because the anatomy of your patient is typically a bit smaller than that. And also, I put this last sentence here on the right bottom because some operators ask me, yeah, but is this all safe, that post-dilatation? I can tell you, well, I've never seen any issue with this post-dilatation, to be honest. And the balloon sizes we are using, they are smaller than the nominal balloon expandable balloon size we would use to treat that particular patient. So if we would use a balloon expandable valve to treat the same patient as with our ACURATE, the pulse dilatation balloon size will be smaller than even the SAPIEN balloon size that we would otherwise use to treat that same patient. So in a conclusion, last slide, to me, this ACURATE IDE trial is really an interesting trial. Unfortunately for Boston, they did not meet the non-inferiority, but I think it really pointed out to something really important in the TAVR field, and that is the TAVR, the underexpansion issue of valves. So the recognition of the importance of the THV underexpansion is important for me, for the entire TAVR field, not only for ACURATE, but also for all other platforms, both self-expanding and balloon expandable valves. We can prevent this with, first of all, an effective pre-dilatation to reduce the risk of this valve underexpansion. There are now also simple new criteria to detect and to identify accurate underexpansion. And if we see underexpansion, we should also do a targeted pulse dilatation to optimize this valve expansion. So in conclusion, I would say for the TAVR field, I think we can learn a lot from the PCI field. In the PCI field, we already know that if we do a PCI in a very calcified lesion, nobody will go for direct stenting. You will go for pre-dilatation, maybe sometimes 2-3 times pre-dilatation with increasing balloons, with cutting balloon, etc. So we have to prepare the landing zone really well. Then we do the valve or the stent implantation, coronary stent implantation. And then, of course, almost everybody will go for a pulse dilatation to optimize the stent expansion in order to reduce stent thrombosis risk and increase the durability of your coronary stent. I think much of these lessons that we learned over the last 20, 30 years in the PCI field, we can simply pull this also into the TAVR field. I mean, we need a good, proper pre-dilatation, especially if we have to deal with a very calcified anatomy. We do our valve implantation, and then we should really check if we have a well-expanded valve. If we have underexpansion, we should address it with a pulse dilatation, just as we do in the PCI field as well. So with that, I want to conclude with this deep dive presentation on the ACURATE IDE trial. And I'm open for any questions, of course.
So thank you very much, Dr. Debark. That's a very amazing talk. And to be honest with you, we noticed not only with ACURATE, even with other form, the people they don't prepare the valve, like before putting putting TAVI. It's ABC, heavily calcified. You have to do the proper pre-dilatation, and if there is a constraint in the valve, you have to do a proper post-dilatation, and you have to look at two orthogonal view. So basically, it is a the study is like, not the valve is bad, but we are not doing the right things to implant this valve. And I think this is the main issue. And a lot of the center, probably they have people with no experience, and they just want to put the valve and let the patient go out from the table safely, but actually they are harming the patient. So we will leave the discussion and question, from the attendees and audience to the end. And we move to the second speaker, Dr. Abdullah Saidi. He's a consultant intervention cardiologist, King Faisal Cardiac Center, National Guard, Jeddah. He will show us a new, like an interesting case, new pathology that's not common in Europe, which is rheumatic aortic valve stenosis. Abdullah, the floor is yours.
Hello, everyone. Thank you for inviting me. Do you see my presentation?
Yes, we do see it. Yep.
Yes. So yeah,
Yes.
my talk is going to be basically TAVI, rheumatic aortic stenosis. Thank you, Dr. Gashgari, for the kind introduction. So I have no conflict of interest to be reported. So generally, we talk about rheumatic etiology of aortic stenosis, usually excluded from randomized clinical trials when included about those group of patients. Those patients usually, in the contrast or the opposite to patients with degenerative aortic stenosis, usually they exhibit significant fibrosis. Calcification is not a big issue in them, at least in the early stage of the rheumatic disease. This actually will basically put challenges for operator when they do TAVI, because the technical impact on transcatheter deployment and anchoring without calcium is going to be difficult. So those patients usually have the risk of migration and basically dislodgement of the valve in comparison to patients with degenerative aortic stenosis. However, having said that, those patients usually they have less risk of having annular rupture because the calcium component of the aortic valve is less in the comparison to patients with degenerative aortic stenosis. So no basically clinical trials done on those patients when we talk about randomization. However, the best basically study done, published in JACC in 2020 about those patients in the comparison of TAVI versus surgical valve in patients with rheumatic aortic stenosis. So in this study, basically, they brought around more than 1,000 patients. Basically, it was a retrospective study looking for SAVR in more than 500 patients versus TAVR in more than 600 patients. And they basically adjusted survival TAVR in the first group versus patient SAVR in patients with rheumatic aortic stenosis. And in the second line, in the right line, in patients with non-rheumatic aortic stenosis, having a big number like more than 88,000 TAVR in those patients, in patients with rheumatic versus patient in non-rheumatic aortic stenosis. So in both basically population, you could appreciate that in midterm, there was no difference in survival. Those talking about patient TAVR in patients with rheumatic versus TAVR in patients with rheumatic, or TAVR in rheumatic patient versus TAVR in non-rheumatic patients. However, having said that, I would say basically as most basically studies showed in the pacemaker rate in patients that underwent TAVR is higher in comparison to patients with SAVR. And basically cardiogenic shock was actually in this study higher in patients in SAVR versus in patients in TAVR with rheumatic aortic stenosis. So without further delay, I'll go to my case. She's a 64-year-old female, diabetic hypertension, and had rheumatic heart disease. She came to our center with dyspnea NYHA class 2. Her labs were within normal. Her ECG, basically, as you can see, showed normal sinus rhythm with narrow QRS complex. Her echo, as shown in the left side, basically showed the classic dooming appearance of anterior leaflet of mitral valve with fixed and tethered, basically the posterior leaflet, classical appearance of rheumatic mitral valve. And the left side and the right side basically could appreciate the short axis, although the images, the windows was difficult, but could appreciate basically the severe stenotic valve without apparent calcification, at least in this view. Basically, in 4-chamber view, you could appreciate in the left side that there was some AI. It's not significant actually in this valve. And here again, you could appreciate that mitral valve also, there is some mild MR without significant stenosis. Basically, the pressure gradient showed the patient has at least severe aortic stenosis. So the patient basically given the options to have SAVR, but she totally refused because her basically sister has an unfortunate event after having open heart surgery and she died. So she totally refused SAVR and we offered her TAVR. You could look at her cardiac CT showed basically the left coronary height on the left side and borderline around 9.5 millimeter. On the right side, basically, it was a generous 15.1. You could look at the images, you see how much there is very minimal amount of calcium, if I can say, affecting the annulus and the LVOT. And you could see here also in the measurements, basically, the aortic annulus diameter was in the range of mean of 21.8. There is no significant difference in the LVOT around 20. Looking also in the same, when we talk about sinus of Valsalva on the left and right and none, could see that the numbers here, and basically at the sinus to pleural junction also, the average was 24.2 millimeter. So looking at axes on both sides are excellent for basically transcatheter aortic valve replacement with minimal calcium. So this category patient, based on the annular diameter, we choose to go with a size 23 millimeter small size of aortic TAVI using ACURATE Neo platform. You could look at her coronary angiogram, showed basically normal coronaries on the left side and on the right side. So here you could appreciate that we want to cross the valve on the left side. Then we managed to basically, after balloon dilatation, in her case using 18 millimeter balloon, we crossed the valve using the platform. And just one slide about important, especially in this patient, looking at the commissure alignment for future coronary access. So the way to do that, basically, you're going to insert the valve in the sheath and keeping the port down at 6 o'clock. This is the first step you do. Then basically looking at two views. The first view looking at the cusp overlap, and this view you try basically to keep the wing on the right side. This has shown basically in this study to have 18% in those patients. Then after that, if done right, you go to step two. Step two, basically in the 3 cusp overlap, you try to keep the 2 wings in both sides. However, if you have difficulty, if one of the wing, both of them on the right side, then you go basically clockwise the device. If the wing on the left side, you counterclockwise. This has been shown in the study that if that done correctly, 80% will have good commissure alignment or no misalignment. 17% will have basically mild sort, and only around 1.8% will have severe malalignment with difficult coronary access. So in this patient, commissure alignment was achieved. We crossed with the valve. And after pacing, basically we did the pacing, the valve was deployed, as you can see, in the left side successfully. And you could appreciate that after valve deployment, we did the next slide to see if there is any valve leak. You could appreciate that actually was excellent result. Could you see also the coronary was done? You can see the dye traveling the coronary. So we did a basically invasive assessment using 2 big tails, and the gradient was around 1 single digit, around 8 millimeter mercury. And next day, echo showed basically again trace paravalvular trace aortic regurgitation with good position of the valve, and patient went home next day. With that, I say thank you for your attention.
Thank you very much, Abdullah. And I think for the time being, we're going to move to our next speaker from here, from Riyadh, Dr. Talal Jabbari from University Hospital. And he will present his case to us tonight. Talal.
Thanks, Dr. Blades, for the introduction. Let me just share my screen. You guys see my slides?
Yes, we see.
Yeah.
Yeah.
At the beginning, I would just, I would like to, sorry. I would like to thank National Heart and Boston Scientific for giving me such opportunity to present in this webinar. This is my disclosure. The case that what I want to present, so basically, so we have a 7-year-old lady with multiple past medical history, comorbidities, including diabetes, hypertension, dyslipidemia, bronchial asthma, and paroxysmal AFib as well. She was initially seen in the cardiology clinic for pre-op assessment before hysterectomy for large uterine prolapse. And then in history, she was found to have exertion dyspnea and NYHI class 2 for many years. There was no history of angina or syncope. An examination, you can see the patient was morbidly obese with BMI of 40, and she was found to have a significant murmur in the aortic area, suggesting severe aortic stenosis, but she was clinically avolemic. Her BMP at that time was about 488. This is her ECG before TAVI, which shows normal sinus rhythm with non-recurrence complex. We did perform an echo, which showed a severe tricuspid aortic stenosis with mini gradient of 66. Her valve area was 0.89. She was also having moderate aortic regurgitation. There was mild LVH, but normal LV function. Also, she was found to have moderate to severe MAC with moderate MS. This is her coronary angiogram. So you can see the right coronary was a small non-dominant. This left main was normal, stroke was large, dominant, but no significant coronary artery disease. However, you can appreciate here the LAD has a severe tight lesion in the mid segment. This is her CT analysis. So you can see the patient has very small annulus, actually. Her perimeter-derived diameter was about 21. The perimeter was 65.9. Her sinuses were adequate. The STTs was about 26, and the average sinuses was about 30, and the sinuses height was about 20. This is just showing the calcification, the degree of calcification. You can see there's only mild degree, despite high gradient. We have only mild calcification, suggesting that the patient probably she has a fibrotic aortic valve. Here, this is just showing the coronary height. You can see here the patient has very low left coronary system. It's actually a left dominant. We need to keep that in mind. So the left mean height was about 8.3. However, the right was adequate at 15.6 millimeter. This is just show, you can see here on the right side, the patient has a significant septal bulge. This is another point another concern that you have to keep in mind during valve implantation or valve release. This is showing accesses. So there was some calcification in the abdominal aorta and aortic arch. However, the coronary accesses were adequate on both sides. So you can see here that this patient highlights a number of issues. So we have a morbidly obese lady with high BMI with a small annulus. This is important to keep in mind in terms of platform of choice. Also, this lady has very low left main, and this is an important since she has a dominant left system. She also has coronary artery disease that might need revascularization in the future. So it's very important to keep that in mind in terms of choosing the device that allow you to have an easier coronary access in the future. And also, if you look to our patient, she's only 70, so she's relatively young. And there is a chance that this lady, she might need another TAVI in the future. So you want to choose a valve that allow you to have another valve in the future. So patient was seen by the surgeon. She was turned down because of her obesity. They felt that she is very high risk. Here, if you apply this, if you look to the valve durability for the index TAVI for our patient, so our patient, she is a low risk and she is 70 years old. So the median survivor for our patient about 12 to 13 years. So that tells you that our patient most likely she will need another valve in the future. So because of that, so we decide to use an ACURATE IDE because it's a supraannular valve that will provide us with better hemodynamics, giving a small annulus. And also we choose the ACURATE IDE because of the shorter frame. So it's we felt it probably will be safe for the low left main. And also because this valve will allow us to have an easier coronary access in the future if we need to fix the LAD. We decide to predilate, to aggressively predilate this valve with a 20 millimeter balloon, which is perimeter-derived diameter -1. And if we need to post-dilate, then we're going to use the same balloon, which is 20 millimeter balloon. We used a commissural alignment, which is, and this is important to allow us to have easier coronary access in the future. And also in case of second valve needed in the future, I think this is important to implement during this procedure. This is just show, this is a 360-degree simulation of the native anatomy of our patient. And this is, you can see the 3D simulation after implanting the ACURATE IDE. You can see that the left coronary access will be okay if you implant the valve in a good position. And that's why we decide not to protect the left main during the index procedure. We also did a redo TAVI simulation as well to assess whether if our patient needed a redo TAVI in the future, what's the risk of left main occlusion. And you can see here, if you decide to implant a balloon expandable valve at the upper crowns, at the level of upper crowns, most likely you will not have an issue for left coronary access. But if you implant the Sabian at the base of the commissural post, you might have a challenging to access the left coronary access in the future. So the case, we went right femoral. Here you can see the 3 cusp view for our patients. Here we pre-dilate with 20 millimeter balloon. Here we're trying to demonstrate commissural alignment. So here we are in the 3 cusp view. You can see that we have like 3 parallel posts. And then here on the left side, you can see in the cusp of lab view, we have only 1 free stent strut. That's suggesting that commissural alignment or favorable commissural alignment have been achieved. And then we went down to implant our valve. So here we opened the upper crown and the stabilizing arches, and you can see how the valve is stable. And then we did release our valve under a rapid pacing because of the septal bulge. Ideally, we don't use rapid pacing with implanting this valve, but in this case, we decided to do rapid pacing during the release of this valve. This is here on the left side. You can see, I mean, if you go back after releasing, you can see the valve is well expanded in the 3 cusp view. And then we went to cusp overlap view to look for any evidence of underexpansion. We felt it's well expanded. And here you can see we try to align all the 3 commissural posts, and you can see they are parallel, and there is no angulated post suggesting that the valve is well expanded. We did the hemodynamic studies, and it did show that the mean gradient was only 6, and you can see that there was from this view, you can see there was no significant paravalvular leak. So post-TAVI ECG, ECG showed a AFib, but no recurrence complex. So there was no any evidence of a high-grade AV block. We did do an echo the next day, which showed a normal V function. Mean gradient increased a little bit to 10 millimeter mercury, but there was no aortic regurgitation. Patient had an eventful hospital course, and she was discharged the next day. And with that, I will end my presentation. Thank you very much.
What an amazing case. Well, I'm very proud of you, Talal and Abdullah. It showed that how our young, talented intervention cardiology dealing with all these complex cases. We're gonna move to our next speaker, Dr. Hussein Al-Zayer. Dr. Hussein, he is a consultant, intervention cardiology, structural interventionist from Al Babtain Hospital. Sorry guys to tell you that I like Hussein a lot, and Hussein, the floor is yours.
Thank you very much, Dr. Wael, for this nice introduction. I'm going to share my slides. Can you see my slides?
Yes, we see it, Hussein.
Excellent. My name is Hussein Alzair. I'm a structural interventionist from Eastern Province, Saudi Arabia. Thanks to Boston Scientific for this kind invitation to present. I have no disclosures. My patient is a 69-year-old gentleman with symptomatic severe aortic stenosis. He had neurocard heart association class 2 on presentation. His past medical history was significant for multivessel coronary artery disease. He declined CABG in the past. He had mild LV dysfunction. His cardiac risk factors included diabetes, hypertension, and dyslipidemia. He had mild CKD. His medication list included DAPT with aspirin, Plavix, carvedilol, amlodipine, phentopril, and atorvastatin. He did not have any allergies. From a social perspective, he was an ex-smoker, and he was very independent. His investigations were as follows. His ECG showed normal sinus rhythm with a narrow QRS. His CBC was fine. His creatinine was elevated at 128. His hemoglobin A1C was elevated. His NT-proBNP was 1910. His baseline 2D echo showed normal LV size with an estimated ejection fraction of 45%. He had normal RV size and function. He had severe calcified aortic valve with a mean gradient of 41 and an aortic valve area of 0.8. He had mild AI. His angiogram showed a codominant system with severe stenosis in the mid-RCA. The left main was unobstructed, but he had severe critical stenosis in the mid-left circumflex and severe calcific lesion in the mid-LAD. His CT TAVI was done and showed a perimeter of 71.4. There was no significant calcification in the annulus or in the STJ, and no significant calcification in the LVOT. His coronary height was adequate. His left main was 12.7. His RCA was 17.9. His peripherals were excellent, and his SDS score was 0.45%. His Euro score was 2.29%. So his case was discussed in the heart team meeting, and the decision was made to proceed with transfemoral TAVI. Given his complex coronary artery disease, we elected to partially revascularize and start with the RCA and postpone his left system to be done after TAVI, given the possible need for rote ablation. So we went on to treat the right, which appeared to be more challenging than expected. We had difficulty negotiating the RCA. We eventually crossed with a pilot 50. We pre-dilated with an NC balloon, and we ended up implanting a long Synergy 2.5 by 48 millimeter stent. There was a minor wire-related perforation at the end, but the patient remained stable and was discharged the following day in stable condition prior to readmission for elective TAVI. So based on the CT, his anatomy was suitable for an accurate neo-size medium valve. His primary access was the right femoral artery, secondary access left femoral artery. We would use the eye sleeve and the Safari extra small guide wire as our workhorse wire for this case. We would pace using a regular transvenous pacer, and we decided to pre-dilate with a 20 millimeter balloon and pre-close with one ProGlide. So the TAVI was as follows. Primary access was obtained by ultrasound in the usual fashion. We obtained an aortogram in the coplanar view to assess our implantation. We then introduced the eye sleeve over the stiff wire and proceeded with our pre-dilatation with the 20 millimeter balloon. We then went in with the delivery system. We did do commissural alignment, although not apparent in these images. We then, after subsequent aortogram to make sure that we're happy with the depth, we decided to release the valve under rapid pacing. And this was the final angiogram, sorry, the final aortogram, which shows patency of both RCA and left system. The implantation depth was excellent in this case. Hemostasis was achieved using one single ProGlide. So this case basically highlights, a relatively younger gentleman with severe coronary artery disease and severe aortic stenosis. We chose this platform specifically to allow us to revisit his coronary arteries in the future and plan possible rotablation in the next few weeks. His post-echo following his TAVI procedure showed excellent hemodynamics with a mean gradient of 4.6 and a peak gradient of 9.5. And this was maintained up to 1 month post-TAVI with a single-digit gradient. And that's about it. Thank you very much.
Thank you, Hussein. It's a very nice case to present, and each platform of each type of platform need to be really studied well, and to be implanted in the proper patient. Different anatomy. There is no one valve for all, so you have to look at the degree of calcification, the left main high, the sinotubular junction, the width of the sinus valva, and the LVOT. And based on that, you choose the proper TAVI platform, like what the three of you guys did. So with that, I will let Dr. Muhammad Belghaith to dive in with the discussion. There is plenty of questions, and the floor is yours, Muhammad.
Thank you very much for Wael and our speaker. I think what we did see tonight, a variety of cases in our society, and if we can see the 3 cases, at least two of them, which is about 60% to 70%, they're a small type of valve. And this is what we are dealing with. The most common valve we are using from the W, to be honest with you, or Medtronic in general, since we start 14 to 15 years ago, it's like 26 millimeter. And this is one of the differences in this society. And regarding the valve for this platform tonight, the ACURATE and ACURATE Neo 2, and the Prime is coming, inshallah, soon to our area. I think it's one of the most stable valve, and this is one of the most fastest valve to be learned in the cath lab. And I can assure you, some of the people here on the webinar tonight, they did only 1 or 2, and they feel so happy. I think what we need to discuss now, to go back to the first speaker and to discuss the trial, to be honest with you. And one of the strange things, 70% of the people who were entered in this trial, first of all, they are more luckier than us. They have only very little experience, and they were entered the trial either from Canada or state, and 70% of them, they did only 5 or maybe less than 5%. And the good news, even in those hands, the success rate was almost 98%. And we need the comment from Ulay here. Do you think it is the design of the valve? Because it's not the experience. Yes, they are expert in other valves, but not in this valve in particular. Go ahead.
Yeah, exactly. I mean, look, you see the success of the implant, and up to 30 days is really, it's excessively good, I would say even. I mean, this is I feel that too if I work with fellows or if you proctor people, after few cases, they know how to implant this valve. They get this valve implanted in a safe way and in a good way. So it's an easy valve to implant. Especially if you follow, for me, it's like a valve. If you have to respect a couple of small rules, like number one, your stiff wire should be nice, placed curve up, nice apically. Secondly, you have to do a proper pre-dilatation. It already went wrong there in the ACURATE IDE that there is data that if you talk about effective pre-dilatation, less than 80% of the valves were properly pre-dilated. Yes, so only 20% was properly pre-dilated, 80% was pre-dilated with some too small balloon. And that is because most of the sites in the US, there are a lot of hospitals and sites who are only balloon expandable implanters. Yes, they only use Sapien as the only platform. So of course, these implanters, they do not have the habit to do pre-dilatation. They don't have a whole range of balloons on the shelf. They only have an 18 millimeter balloon on the shelf. Because you use a balloon differently if you use a balloon expandable valve, then it's just because you are afraid that you cannot pass the valve through the very calcified valve. So you don't need a proper good big balloon. But this is different if you do other balloon implantations and pre-dilatation for a self-expanding platform. So I think what is really important is that not only that we run out of the cath lab as soon as the implant is done and there is no PVL and there is no gradient. By the way, there is never gradient with ACURATE because the hemodynamics is so good that even if the valve is underexpanded, you don't have a gradient. Yes. So that's the problem. The operators, they didn't see PVL, they didn't see gradient. So they thought, okay, I leave the cath lab up to the next case. But they forgot about the fact that the valve should be properly expanded. And they also missed it because they only were working in a tracheostomy view. They never checked even once in an REO view, which we normally do, yes, with other platforms. So I think the big learning for us is that, well, ACURATE, it's an easy valve. Even in unexperienced hands, people are able to repetitively implant this valve in a good way. But don't forget the pulse dilatation if there is severe underexpansion. And that's the only lesson I learned, I think, from ACURATE IDE. It's just a shame, of course, that now they missed the non-inferiority in their ACURATE IDE, but I know there are talks going on with the FDA in the US to see how this can be solved now that the root cause has been identified. Probably they're gonna be happy. I think I cannot say more. I've been involved in these talks, but and there's no decision being taken. But it could be that they ask for an expanded population for 500 more patients, where they show that if you do this proper implantation technique, that indeed the outcomes are as good as the control arms. So that could be that they ask for a prolongation and extension of the cohort. Yes.
Okay, so that's very interesting. So the key. So go ahead, Mohammed.
For more discussion, Ryan, go ahead.
Yeah. So what I learned honestly today from the case presented by Ole is yes, the gradient probably single digit, but you have to eliminate like the under expansion to prevent future valve degeneration. This is very important. Pre and post dilatation, it will take 1 or 2 minutes. I think it is a great valve, and I think we need to do more exercise, to implant it in the proper way. So I will take the first question from the chat, Muhammad, and then if you don't mind, you go ahead and continue the question. So there is one by Osama Bashid is asking what software was used for the valve-in-valve simulation. I think, Ole, did you present a case valve-in-valve?
Valve-in-valve, no, I did not present it here, no.
So
I think he's commenting on Talal Jabbari, maybe.
Talal, what software you used for the 3D?
Yeah, that was actually Safari Small.
What is the name of the
Safari Wire, Safari Small.
No, the software for the simulation.
Oh, yeah,
Dr.
that's
Wyatt,
actually was
Dr.
done by the
Wyatt.
yeah, actually that was done by the company from
Somebody,
Boston.
somebody.
They did it for us.
I,
So I'm not,
why
means-
Boston don't do it for us also? Is it,
Yeah,
Talal, I know Talal is special, but you should do it for us also.
I mean,
think
if you
he
ask
means-
it,
he means-
Now something different here is okay. Because Talal is a good guy and he's a close friend, we'll let it go. So next question, Muhammad.
There was a question there, but I think it's a simple question. Anybody can answer, either Wyatt or late. Somebody asking if you do a pre-dilatation, then you will need to do post-dilation. He's asking if the post-dilatation will affect the coronary.
Yeah, I can answer on that. First, pre-dilatation, it does not affect the coronary. I mean, I pre-dilate almost all my cases, and I can say pre-dilatation is really a safe act. I mean, it's never been related with coronary issues, never been related with stroke issues. There is no data on it, and I do it already for many, many years in almost all my cases, and I've never seen issues with that. The second, yeah, if you do more pre-dilatation, whether you maybe have to do less post-dilatation. That's probably true. I mean, if you do a really good, proper pre-dilatation, you probably have more chance that you have an immediate good valve expansion and implant, that you have to do less post-dilatation. That's probably true. And that's also what I would advocate. I mean, I would advocate for a good, effective pre-dilatation, do the valve implant, and then maybe in 1/3 of cases, you maybe still have to post-dilate if you think there is under expansion. If you do a lousy bad pre-dilatation, maybe you have to post-dilate 60-70% of your cases. So it's better always to do a proper pre-dilatation. It's mandatory to do it, and then probably you can reduce on your post-dilatation. I think that's the way to go. By the way, I can also share with you that pre-dilatation, for most of the implanters so far, maybe also for you, it's just one act. You say it's pacing on, inflate the balloon, and you're done. That's not for me. I mean, sometimes I also use the ACURATE platform for very calcified cases. You can do it, but then you have to, I repeat sometimes my pre-dilatation balloon. So I do pacing on, inflate my balloon, deflate, stop pacing. I let the patient recover for 20-30 seconds, and I repeat my pre-dilatation. And by doing this repeated pre-dilatation, I've definitely modified my calcium in a better way. I break it better so that I make sure that my valve expands good, even in very calcified environments. So this pre-dilatation is also something you can play with. You can use, you'd have to do it patient tailored as well. Like if it's mildly or moderately calcified, fine, classical single pre-dil. But if it's a very, very calcified environment or bicuspid cases, I pre-dilate almost systematically with a double tap. We call it double tap pre-dilatation. I do that. Yes.
So one of the technique I used for the bicuspid, especially type 2, I used biplane camera for the pre-dilatation balloon. I look, because sometimes you look from the front, the balloon is fully expanded, but if you look from the other side, the balloon is under expanded. So that's make me go with a higher balloon. So we have about 7 cases, type 2 bicuspid aortic valve, where we did the balloon. You can see clearly from one side is inflated, as you show in your nice slides, Ole. But in the other side, the valve look really, really under expanded. So it gives you the courage to do further dilatation. One another question here. I think I will let this question to be answered by Muhammad Balghair. He said the first case with rheumatic heart disease expected to have another valve in the future. Please explain what is the advantage of this platform in comparison to another device. Thank you.
I think Boston Scientific, we are using it now for about a few years. And I can assure you, till this moment, because it's an early use, we never had a degenerated type of TAVI from this type of platform yet. But I think it's very reassuring, even for any intervention now with the coronary artery disease, to go ahead and engage the coronaries. in comparison with other platforms. Yes, from other, especially the first generation, to be honest with you, the first 4 valve, 14 years ago, we had some problem with the right coronary engagement. Just engagement, with the long term, we had a problem with engagement. That's one of the most difficult we face. And in the beginning, there was a lot of things about or commitment, even from the expert proctor when they came into the Middle East, about the commissioner alignment, like 15 or 14 years. But I'm very optimistic with this type of platform, with this wide cells, even putting a valve in the future for some of the rheumatic cases, it will be okay. I think our colleagues, Egyptian, they have a good number of rheumatic heart disease treated with TAVI so far. And they presented at least, I think last year, they presented 30 cases from one center. They are more expert or more volume rheumatic heart disease than us with the TAVI.
Yeah, Mohammed, maybe if I may, I want to share maybe a slide I can on redo TAVI. Can you see my slides here?
Yeah, beautiful. That's excellent. Go ahead.
Look, so because we're talking about this topic, so typically revalving valves, so the second valve is very often good, a balloon expandable, a short stented frame to revalve other valves. So here what you see is SAPIEN and SAPIEN, SAPIEN and Navitor, SAPIEN and ACURATE, SAPIEN and Evolute, you see? So you see what the beauty with ACURATE is, in fact, if you do an ACURATE implantation, and you have to revalve this valve. Typically, you go with a balloon expandable valve to revalve the ACURATE. And you see here, I want to point you out to the functional nail skirt, how low this is. This is actually even lower than SAPIEN and SAPIEN, you see? So here, the dotted line here, you see the functional nail skirt. It goes even as low and lower than SAPIEN and SAPIEN. SAPIEN and Navitor is also relatively low, but then still you are dealing with the nitinol frame there. And it's a complete, it's much harder if you do SAPIEN and Evolute. First of all, the Evolute platform has a very dense nitinol network, and it has the highest leaflet position of us all. So even if you go for a high SAPIEN implantation in ACURATE, you see that still, thanks to the very nice big open stabilizing arches, they don't interact with your coronary catheterization. And even you will never really have issues with coronary access, even if you go for revalving of an ACURATE. So that's in a way a beauty of this platform, that this is a valve which is also really good for the future for patients who need to be revalved, so for younger patients. So I think it's a great platform. I mean, really, it's an addition. I use, of course, all different platforms in my center, but there are this valve has some particular aspects which make it really nice for small anatomies, patients at risk for pacemaker, patients where you need coronary access in the future, patients who need maybe revalving in the future. I mean, there are some or small anatomies indeed where you're concerned about hemodynamics. So I think there are really some or horizontal aortas. So there are some really nice aspects. It's really an addition to your TAVR to your TAVR platform or to your TAVR program, sorry, in your hospital. Yeah.
So there is a claim that this is the best valve for young, relatively young patient for the future, valve in valve, and you explain it very well. I think it's a great valve, honestly, and we just advise the people, as explained very well by Ole, is really do all your effort to give us this a beautiful valve, fully expanded, as a gift for the patient. Another comment here by Ibrahim Ali said, uniquely designed with an open frame and supraannular leaflet, make it excellent valve for good selected patient, as we now that no single valve fit for all patients. Totally agree. Every valve platform had pros and cons, and absolutely right. I'm just quickly reading the comments. So using the right balloon size for pre-dilatation, not too small. That's said by Ole and is the main
Yeah.
reason why the study was not very supportive. Athir said, what is the type of balloon that you will use it for pre-dilatation of the valve? So
Yeah.
what do you use, Ole?
Yeah, most of the time I use non-compliant balloons, like a true dilatation balloon. But to be honest, I'm not so extremely picky on that. I mean, I can also work with semi-compliant balloons, so it's not as important for the pre-dilatation. For the post-dilatation, if you want to do a real proper post-dilatation, maybe a non-compliant balloon, then you're really sure that the balloon gets to the size you really chose. But anyway, I think it's less important.
Name it, Ole. What is the non-compliant you use, and what is the compliant balloon use? So name. So
Yeah,
to
so
compare, what do you have in here in Saudi Arabia and Middle East?
But we don't have the same balloon. Sometimes we have in Denmark. I remember when we visit you and Lars and Fadi were using different type of balloon. I was surprised we don't have it.
Well, the non-compliant balloons are the true dilatation balloon of BART, which is a very popular, well used balloon for sure in Europe and US. I don't know if it's in the Middle East, the true dilatation balloon.
Is it the same true for fracturing the valve, Ole, or it's a different?
Yeah, exactly. You can only fracture a valve with a non-compliant balloon, with an NC balloon, non-compliant. So the semi-compliant balloons we have is like Osipka balloon. I know there is a valve on the market, a Turkish balloon. I think it's Sim valve called something like that. It's a little bit in between a semi-compliant and a non-compliant. It's not a bad balloon, but they sell it like a non-compliant. It's not a fully non-compliant, but it's better. It's more strong than a semi-compliant. So it's something Sim valve balloon or something. We have had it too. So there are a couple of different types of balloons, but again, I think it's less important which type of balloon it is than you take the proper size. You know, don't take an 80mm balloon if your patient has a perimeter-derived mean diameter of 23.8. The smallest balloon you should ever use when implanting an ACURATE should be 22. It should not be smaller. Yes, it should be a 22 or 23 balloon. So it's more the size which is important than whether it's semi-compliant or non-compliant. It's kind of less important, so I think.
Yeah. So what we have in Saudi Arabia, and I think in most of the Gulf and Middle East, is the crystal balloon and the Z-mid balloon. So this is really the good semi-compliant because like it's very difficult to do a test or specific test to define what is the semi-compliant. We just trust what the manufacturing company is telling us. But we know from our experience and the congenital background that Z-mid balloon is very good for a pre-dilatation. The crystal balloon is very good. The non-compliant is the true and the Atlas Gold. So I would, the majority, I think Muhammad, he can comment on that. They go with Z-mid and the Z-mid between two brackets. Some company, they call it nucleus. They are the same. And then the crystal balloon, which is the widely used, and both of them, they are the least for rupture. The tie-shack balloon is a baby Lala balloon for aorta. I don't advise people to use the tie-shack for aorta. Tie-shack is only for pediatric valvotomy and not for the adult. Or maybe you can use the tie-shack for sizing something, for doing test occlusion for something, but not for the TAVI. So, Muhammad?
I think for me and you, we share the same product, Riyadh and Jeddah National Guard. And in the old days, we used to have nucleus, NUMID, and Z-mid. Nowadays, mostly Z-mid. Rarely Atlas, but in our colleagues, the adult congenital, they have a special type of balloon, which we are not using it routinely.
Yeah, the Atlas Gold balloon is a non-compliant balloon, but it's not the easiest balloon because it takes very long to inflate. It takes like 15-20 seconds, and then it's very slow. So I would not recommend using it, especially because we do these TAVI procedures sometimes with patients in local anesthesia, conscious sedation. So then otherwise they pass out completely. And maybe to end with, I mean, it's maybe still nice to share a bit of my experience with the ACURATE Prime, because we have do you have ACURATE Prime in Saudi or not?
Not yet.
Not yet.
No. Well, you can look forward to it. I mean, really, it's an improvement again. It's really nice to work with. The valve itself, the implantation technique, and the way we discussed is exactly the same. But there are a couple of small iterations on it, like the radial force has been increased. So in the past, with the ACURATE Neo 2, the ACURATE Small was the valve with the biggest radial force. And then when you went to the larger sizes, the medium and the large, you actually lost a little bit of radial force. So what the engineers now did is they made, now you don't have the free stand strut anymore, so there's more equal radial force. And they brought the radial force to the level of the small. So the small, medium, large, and extra large, they have all the same radial force as high as the small from the ACURATE Neo 2, which is good. So the radial force increases. And also, especially knob 2, the final expansion of the body, stand body in the bottom, it's much, much quicker. It's quicker and more robust. It's like very swift. And I like it because you do all what you can as an implanter to be as correct and precise as you can. And then with a small 90-degree turn, you don't have to turn like very quick on the handle anymore. Just with a simple 90-degree turn, the valve also comes more swiftly and quicker off. And so I think there is good experience in Europe already now for a couple of hundred of cases. And I've heard really good feedback also from my colleagues. And I also love it myself. It's really an improvement again of the product. So that's something to look forward to in Saudi as well. Yeah.
So, Mohammed, do you want so the message of this meeting, which is part of the National Heart Center virtual webinar in collaboration with the Saudi Arabian Cardiac Intervention Society. The message, usually we have a message when we do such webinar. We want to assure the community, especially the patient who had this valve before, and now they get back to us with tons of questions about this study. We assure them that the valve, especially in Saudi Arabia, implanted, as you see, by the nice cases presented by Hussein and Talal and Abdullah Saidi, was implanted according to the textbook. Yes, we learned today as the intervention community that we need to do a proper pre-dilatation, post-dilatation, give the frame the beautiful shape of it. And this is the message we want to relay to the community as a National Heart Center and SASIS. And the final comment, I will leave it for Dr. Mohammed Balghet and Ole. We have another couple of minutes, and thank you very much.
Thank you.
I think I will let Ole talk first.
Yeah, maybe I go indeed first, and you can do the final comments, Mohammed. So what I want to say is first, I want to still congratulate also all the presenters of the cases. These were really beautifully executed cases. Really, honestly, they were textbook cases. It shows how much expertise there is also in your region and in your country. It's really amazing to see this. And to me, this is the success of TAVI. You know, TAVI, why is TAVI so successful? It's because it's so standardized. You can standardize it all over the world. Yes, they do it the same way as I do it in Copenhagen, and that's the success. That's the key for success of TAVI. That's the problem of surgery. I mean, surgery is less standardized. Yes, you can have a brilliant surgeon in this hospital, but in another hospital 10 kilometers further down the street, there's maybe a lousy surgeon and he has much worse outcomes. This is different with TAVI. You see, if you educate, and that's what this tutorial, this workshop is also about, this 1.5 hour we're talking here on this Saturday evening, is just to educate people, to learn how to use the device, how to select patients, what patients are good or not good. You see, there's a lot of investment in optimizing these TAVR outcomes to standardize it. And that's the key, that's the success of entire TAVI in the entire world. Yes, and congratulations again to the presenters.
I would like to thank everybody today, especially our younger cardiologists. They did a great job, to be honest with you. And thanks our colleagues and friends, Ole, who was always helpful to us. And we would like to thank the National Heart, thank Weil and SASIS. And I think the summary of this, as we heard about it, yes, there is a new trial which was presented, and there was some issues with it, but this is not abnormal. This is the medicine. We had the same problem with mitral clip. We were in France, then we went to state, and things changed in less than 1 year. I'm not surprised. We are happy with the device we have. To be honest with you, in this country, we had a good experience, and in the Gulf states, we never had any big issue with this platform. We are happy with it. We're going to go with the recommendation which was sent to us and to the practitioner by the Boston Scientific, and we're going to follow the steps. So far, we are happy. Thank you very much for everybody and for our attendee and for our young colleagues. Thanks.
Just a quick statistic. The actual patient, actual attendee is about 61. 3 of them, they present the entire lecture in auditorium. So I will, we're going to share this photo in our website. There was one of the site, 32 person attending this lecture in one hall. Congratulations for everyone. Love you guys.
Thank you so much.
Thank you.
Great job,
Thank you.
everybody. Bye-bye.
Have a great
Thank you,
time.
Abdullah Saidi. Dr. Abdullah Saidi, thank you very much.
يعطيك. يلا
See you
سلام.
tomorrow.
Thanks.